So thank you everyone for joining again. My name is Sarah Thompson and I am an outreach specialist with the University of Wisconsin Center for Tobacco Research and Intervention. I'm joined today by Miranda Medina Lopez, who is a tobacco treatment specialist and the community outreach coordinator and bilingual health educator with the Wisconsin Women's Health Foundation. And we are here to talk to you today about how to address tobacco use in pregnant persons, particularly in those who have substance use disorders. A few housekeeping items while we get started. And while we do that, I'm actually going to pull up a poll. If you wouldn't mind just answering the poll, it gives us some context for who's joining us today. So while you're filling that out, a few housekeeping items. This presentation, as you've seen, is being recorded. The slides as well as the recording will be made available after the presentation, and you can find those located at helpusquit.org. We will send up some follow-up information as well. Just a reminder to please mute yourself when you are not speaking. It helps to avoid any of the echo and background noise and just helps keep it clear and crisp for everyone. So please keep yourself muted. If you do have questions, you are more than welcome to submit those in the chat box. We'll try and answer them if we are able in the chat as we go along. And we'll try and reserve some time for questions at the end of the presentation as well. A note about our project partners that I want to acknowledge. This webinar is part of a larger project working in collaboration with the Wisconsin Division of Care and Treatment Services and the Wisconsin Tobacco Prevention and Control Program. We've provided some general training and technical assistance to DHS 75 providers starting a few years ago when DHS 75 was revised in 2021. That partnership has allowed us to provide some general training on how to integrate tobacco treatment into behavioral health settings, particularly in substance use disorder treatment and recovery settings. According to the poll, we do have a number of DHS 75 organizations represented on the webinar today. So that's great to see. As many of you may know, DHS 75 does prioritize the treatment and admission of pregnant individuals into SUD treatment and recovery. So in addition to that prioritization, we recognize the need for specific tailored support in individuals in treatment for specific tailored support and treatment for individuals who are pregnant and during that perinatal period. So our goal today really is to provide some more context about this population, more background and information, and for everyone to walk away with a next step in how they can better tailor their approaches to treating this population. So our agenda for today, we're going to break this webinar down into two separate parts. In the first part, we're going to talk about that background and context, just provide a little bit more information about what the landscape looks like for tobacco use during pregnancy. We'll recognize some of the important risks involved for those who use tobacco during the perinatal period, particularly among those who have co-occurring substance use disorders. And then we'll close out part one by reviewing some evidence-based tobacco treatments and really focus on those supportive resources that are available for individuals during pregnancy. You may be familiar, one of those resources is First Breath. It's an excellent Wisconsin program unique to Wisconsin. And by the end of the training today, if you stay on for the duration, you will be able to become a First Breath provider and will be ready to provide referrals to First Breath for any patients or clients that you work with. So getting started, in the chart here on the right-hand side, we can see smoking prevalence among US adults in the general population. In the 1960s, we see that we had smoking prevalence rates of over 40%. And since that time, we've had very progressive, fairly steady declines in terms of declining smoking prevalence rates. In 2022, the general population saw a smoking prevalence rate, nationally speaking, of about 12.5%. In Wisconsin, we're a little bit higher, closer to about 15% of all adults in the state. However, despite this progress, tobacco continues to be the #1 cause of preventable death and disease in the United States. Each year, tobacco kills almost 500,000 Americans each year. That's about 1 out of every 5 deaths is directly caused by tobacco use. When we narrow in then on tobacco use during pregnancy, we see similar trends in terms of declining prevalence rates over time. This chart here shows us both prevalence rates for the United States as well as Wisconsin. And some of the most recent data looking at Wisconsin shows a prevalence rate of about 8.4% of individuals smoking during pregnancy. It's important to note, however, some potential limitations on this data. When we ask about tobacco use and prevalence rates, there can be some stigma and shame associated, and people might be hesitant to disclose their tobacco use, particularly during pregnancy or the perinatal period. So there might be a little bit of underreporting on that front. Additionally, some individuals who might not use tobacco every day, they may use it in a more intermittent basis or might use tobacco products like e-cigarettes and may not necessarily identify as a tobacco user. So because of this, we might actually see some underreporting in this data. When we look at that smoking prevalence rate in the state of Wisconsin, again, we saw in about 2021, 8.4% of individuals were smoking cigarettes or using tobacco products, but that 8.4% isn't evenly distributed throughout the state. When we look at smoking prevalence rates broken down by county, we can see certain areas of the state, people are more likely to smoke during pregnancy than in others. And this chart shows that county breakdown, with the darker red counties having higher prevalence rates of smoking during pregnancy. And you can see that it's somewhat concentrated in northern areas of the state, or which may tend to be more rural areas of the state as well. We see some smoking prevalence disparities. There are a number of other factors associated with tobacco use during pregnancy, such as education level, educational attainment, or marital status during pregnancy. We also see that access to prenatal care or completing prenatal care is associated with tobacco use. People who do not access any prenatal care are much more likely to smoke throughout their pregnancy compared to people who start receiving prenatal care during the first trimester. And additionally, one more really important disparity to look at is in terms of racial and ethnic backgrounds. This chart shows smoking prevalence rates during pregnancy, both in the United States and in Wisconsin. Again, similar to those other data looking at just general smoking across the state. We do see higher rates in Wisconsin compared to the national average, really across the board, racial and ethnic wise. It's important when we talk about all of these disparities, though, that there's a broader context for why we see these disparities. And a big reason for that is the targeted marketing and advertising on behalf of the tobacco industry. We can't fully get into this topic today, but it's a topic that's been well studied and well understood, that the tobacco industry has specifically made targeted marketing and advertising in specific publications among certain communities and certain venues. They've sponsored a number of different cultural events that might lead and contribute to tobacco use disparities across the board. One really important one to note is the use of traditional tobacco, particularly among some American Indian and Alaska Native communities. Although some of these communities have a use for traditional tobacco that has a very strong cultural significance, that cultural and traditional background has really been romanticized and been used as a marketing tactic. Some tobacco products are marketed as being natural, as having a spiritual experience. when in reality, we know that this imagery, this language is really misappropriating Indigenous culture. It can reinforce harmful stereotypes, and additionally, it can confuse the line between traditional and commercial tobacco and make people more likely to engage in a behavior, maybe not fully understanding that important distinction. So we understand then that marketing and advertising is part of the broader context, and there are a number of other factors called social determinants of health in the world we live in around us that might influence our decision to initiate a certain behavior, whether it be tobacco use or otherwise. And these factors might not only encourage someone to initiate a behavior, but it'll make it easier for them to continue and ultimately become barriers when they want to make a change to their tobacco use. They might make it more difficult for someone to stop. For example, if they have to travel a long distance to reach a healthcare physician or a healthcare system, they may not readily have access to receiving adequate treatment and appropriate support to make the appropriate changes and to understand their treatment options. Okay, so kind of understanding what tobacco use looks like in the state of Wisconsin during pregnancy, let's focus in on what it actually looks like in the body. There are two main derivatives of smoking that have an negative impact on pregnancy outcomes. The first primary derivative is nicotine. This is probably familiar to you. Nicotine is the primary substance in tobacco products that mediates the addiction to tobacco. In addition to being addictive, nicotine is a known neurotoxin, and exposure to nicotine can interfere with the normal neurotransmitter function. This in turn can be harmful to the developing fetus and affect brain development and nervous system development in the infant and child. Interestingly enough, nicotine is actually concentrated in the fetal compartment. So if the pregnant individual is smoking, the fetus, the baby, is going to be exposed to a higher level of nicotine than the pregnant individual is themselves. The second derivative that has been studied to be harmful to fetuses is carbon monoxide. And carbon monoxide probably also sounds familiar to you. It is a toxic gas that is contained in cigarette smoke. Carbon monoxide monitors are frequently used to test if someone has smoked in the past few days because it indicates if carbon monoxide is present, it indicates that someone has been smoking, and is frequently used as a way to just track people's progress if they're working on quitting. What carbon monoxide does is that it reduces the oxygen carrying capacity in the blood. So if there's not enough oxygen, that can impact vital organs, the development and the functioning of organs. Exposure to these derivatives of tobacco products and others can lead to a number of different risks during pregnancy. And there's really clear evidence of the strong association between tobacco use and a number of different serious obstetric related risks. Prior to becoming pregnant, tobacco use can increase infertility in both females and males. When someone becomes pregnant, tobacco use can increase the risk of miscarriage, preterm birth, premature rupture of membranes, ectopic pregnancy, stillbirth, gestational diabetes, as well as a number of issues to the placenta, such as placenta previa, where the placenta attaches low in the uterus and it covers part of the cervix or completely covers the cervix. This can cause severe bleeding, and if it doesn't correct itself on its own, then the baby would need to be delivered by a C-section. Tobacco use can also increase the risk for placental abruption, which is where the placenta separates from the wall of the uterus, which can lead to a lot of pain and bleeding in the pregnant individual, but it also is going to limit the nutrients and oxygen that the baby is going to get in the womb, and they may not be getting sufficient resources. So looking at the risks then to the child, both while it's in the womb and after birth, the link between tobacco use during pregnancy outcomes has also been very well studied, and the evidence really is unequivocal. It's estimated that 20% 20% or more of low birth weight births could be prevented by eliminating smoking during pregnancy. Other fetal risks that are increased with tobacco use are growth restriction, potential birth defects in the oral facial clefts, limb reduction or heart defects, as well as a number of neurologic or neurodevelopmental effects. After birth, risks to tobacco use include sudden infant death syndrome, known as SIDS, respiratory effects. It can impact cognition and behavior, increasing the risk for diabetes, childhood obesity, psychiatric disorders, as well as potential future substance use. Parents who use tobacco are much more likely to have children who use tobacco than parents who don't. There was one study looking at children in grades 4 to 6, and this study found that children who lived in a home with at least one person who smoked were 3 times more likely to have smoked in the past 30 days. So current use, it's not necessarily predicting future use in adulthood, but during grades 4 through 6, if they lived with someone who smoked, they were 3 times more likely to have smoked in the past 30 days. We also want to acknowledge the importance of avoiding passive smoke exposure. Many of those risks I mentioned to the fetus and the baby are not limited to the pregnant individual. There's some research to show that secondhand smoke exposure during pregnancy is also associated with many of the same adverse pregnancy outcomes. For example, pregnant women who are exposed to secondhand smoke are estimated to be 23% more likely to experience stillbirth compared to people who are not exposed to secondhand smoke. And this also has implications, speaking postpartum, when after the baby's been born, both for the pregnant individual as well as people surrounding them. We know secondhand smoke can impact our lungs almost immediately. The effects start right away, and this can increase risk for certain respiratory infections, asthma, continues the risk for SIDS and some other middle ear infections. Okay, so we talked about tobacco use in pregnancy. Now I want to switch gears and talk about tobacco use for individuals with co-occurring substance use disorders. Our chart here shows smoking prevalence broken down by different substance use and substance use disorders. It shows different ranges for each substance, and I don't want to get too caught up in the numbers, just the general idea. People with substance use disorders are 3 to 5 times more likely to smoke than people without substance use disorders. And those who use multiple other substances have even greater odds of smoking than people who might just use one substance. To further this idea, focusing in on Wisconsin, there was a study completed a few years ago looking at smoking prevalence rates among people who lived in rural areas in Wisconsin and surrounding states, looking at those who inject drugs. And that particular study found that more than 92% of people reported smoking at that time. To understand that co-occurring use, polysubstance users often report, and it's confirmed by a lot of research, that co-use of multiple substances oftentimes increases the use of one or both substance. So for example, alcohol can have some sleep-inducing effects. It can make people feel tired or drowsy, and tobacco has some stimulant properties. So those stimulant properties can counter any of the sedative or intoxicating effects that alcohol might have. And this in turn might allow someone to drink more, ultimately allowing someone to use more tobacco products to continue countering those effects. So we can see how these behaviors might become part of a ritual. They can oftentimes become paired actions. Substances can cross-reinforce one another, and tobacco is very commonly one that's used to cross-reinforce and can provide some level of cross-tolerance, allowing people to consume more of one or both of those substances. This then in turn can lead us to understand when we understand how those behaviors become paired or linked, that it's important and has potential implications for how we treat co-use of substances, particularly with tobacco. And when we look at what the research says about co-treatment of tobacco during substance use disorder recovery, there really is no evidence that if someone treats their tobacco use while in treatment or recovery for another substance, there's no evidence that they're likely to increase the use of the other substance. In fact, research shows us quite the opposite, that co-treatment of tobacco use during SUD treatment actually enhances our long-term sobriety. It enhances that long-term abstinence. People who quit tobacco use while in recovery are 25% more likely to maintain abstinence from all substances, not just tobacco, not just their opioid use, but they're 25% more likely to maintain abstinence from all substances. And the opposite for people who continue to use tobacco or start to use tobacco while in recovery, they are actually more likely to relapse to those other substances and to do so more quickly. Okay, so we want to focus in though on that intersectionality. How do we bring this all together? I have my Venn diagram here of pregnancy, substance use disorders, and tobacco use or tobacco use disorder. And we want to focus on this middle section. Unfortunately, because of how Venn diagrams work, the middle section is going to be our smallest section. But that is actually really misrepresenting this population. It should be much larger in proportion compared to where other circles are overlapping. Data show that 85 up to 95% of pregnant individuals who are seeking treatment for alcohol and other substances use tobacco products. So that, again, reiterating that center section should actually be much larger in proportion to those other overlapping spaces. On top of this, when we look at pregnant individuals, smoking prevalence may be up to 4 times higher than pregnant persons without SUD compared to pregnant persons with some diagnosed substance use disorder. And the reason, again, that intersectionality is so important, we know it's important for the treatment aspect, but it also has implications for the baby as well as the mother. There are potential additive risks for the adverse fetal outcomes with co-substance use. The risks of opioid use and tobacco use, for example, don't remain independent, but actually may have an additive risk and make the symptoms or potential health effects even more significant. For example, babies exposed to substances while in the womb are at risk for something called neonatal abstinence syndrome. For those who don't know, it's essentially when the baby is exposed to a substance. Once they are born, they may go through a period of withdrawal. And the symptoms of that withdrawal can really vary depending on the substance. Most often this applies to opioids, but it can apply to a number of substances. And they can vary depending on the duration, the amount that someone was exposed to it, the time that they were exposed to a substance, the number of substance, etc. But if a baby, while they're in the womb, is exposed to smoking and tobacco use, that smoking predicts a greater duration and severity of the symptoms that the baby is going to experience once they're born. So we can see that it really demonstrates that potential additive risk for the baby. On top of those additive risks, research shows that smoking may be more of a contributing factor to low birth weight than other substance use. And ultimately, eliminating smoking would have a greater impact on decreasing poor birth outcomes than elimination of any other substance. To not be so doom and gloom about things, there are a number of potential benefits to smoking cessation during the perinatal period that impact both the individual, the baby, as well as others around them and their family. Quitting early during pregnancy, making changes to tobacco use early in the pregnancy, the first trimester, is going to give the greatest benefits to the fetus. Even though that's going to give the greatest benefits, that doesn't mean there aren't potential benefits throughout the pregnancy. There are certainly benefits to making changes to tobacco use and other substance use at any point in the pregnancy. They begin almost immediately and will continue to improve over time. So it is never too late. If someone is ready to make a change at month 6 of their pregnancy, there are still many, many benefits that they can get from making those changes. Okay, so what can we do? We understand that this is a really important topic. What can we do about it? Our evidence base for treating tobacco use is detailed in the clinical practice guideline, treating tobacco use and dependence. And there are really 2 primary elements involved in treating tobacco use on the individual level. The first is the use of medications. There are 7 medications approved by the FDA specific for tobacco cessation. Unfortunately, there's really insufficient evidence for use of medication during pregnancy at this time. It is recommended, however, that anybody who uses tobacco talk to their physician and explore their options, particularly during the prenatal and postpartum visits. So the second primary element, and because use of medication may be limited, the second element becomes that much more important, and that is to provide counseling. Counseling can be brief and includes skills-based counseling, problem-solving skills, etc. This can be in the form of cognitive behavioral therapy, motivational interventions, in addition to other skills-based counseling methods. The guideline shows us that as little as 3 minutes of having brief counseling can be effective at helping people make positive change. But that being said, the effectiveness of counseling is going to increase with treatment intensity. So the more time we spend talking to people, working through problem solving with them, the more beneficial it is going to be for the individual. Another piece to that counseling component, and should be provided as a part of the counseling treatment, is the social support. So this is going to factor in the world around them, the networks that people have, and just providing more conversation to help people work through the challenges that they face. And given all the barriers to cessation that individuals face, the disparities that people might factor in, stigma, trauma that people have experienced, the serious risks of using tobacco product, limited evidence on medication, these all really point us to providing strong evidence-based counseling and additional social support. More practically speaking, what can you do to support clients? Starts with tobacco integration. So we want to start with assessing for tobacco use, understanding which of our patients and clients are using tobacco products and what that might look like for them. Once we have completed an assessment, we want to work through the treatment process, including tobacco use in a treatment plan or in someone's client chart. So understanding that it's a part of their pregnancy, their substance use disorders, or whatever other health concerns that the individual might have. This tobacco integration is something that we have discussed on a number of other different webinars. We have a number of print materials, toolkits, resources, fact sheets that are available to help in this process. So we're not necessarily going to focus on tobacco integration today. If you're curious about what you can do internally at your organization, I encourage you to visit helpusquit.org to see some of those many resources. Otherwise, if you prefer to interact with a person, we are here to help. I am the Northeast Outreach Specialist, and I serve 25 counties in northeastern Wisconsin, but I have counterparts in all regions of the state, and we do cover all counties. So if you are interested in receiving free training and technical assistance from me or the other outreach specialists, we are more than happy to help figure out how to integrate tobacco into your clinical workflow. And if you're not quite sure what the next steps would be, we can help you kind of figure out where you're at and figure out what an appropriate next step might be for you. Now, to support that tobacco integration, we have 2 support services that are really excellent at providing that additional support for individuals. Um, they're not necessarily meant to take place of internal tobacco integration, but it really are meant to support and complement anything that you're already doing clinically. They're going to be treatment extenders. They're not meant to replace, they're going to be treatment extenders to provide additional support. And I'll talk about each of these 2 resources on the next slides. Again, whether we're fully integrating tobacco treatment into our practice or are going to focus on referring to one of those 2 supportive resources, we always want to start with assessing for tobacco use. You can build that assessment into the intake or assessment forms you're already using. It is recommended, it is evidence-based to start by documenting that tobacco use in the client chart or in the treatment plan, recognizing it as essentially a vital sign for medical settings. So you can start by just asking, have you used tobacco products in the past 30 days, including cigarettes, e-cigarettes, smokeless tobacco, cigars, etc. We want to make sure that we're capturing a number of different tobacco products to make sure that people are identifying where they fall within this question. So you might notice this is a yes or no question. Essentially, we know that no level of tobacco use is safe. So if someone screens positive to this question, that's going to indicate we're going to need more assessments to help identify appropriate treatment and support options for the individual. So that's when we can start to bring in more open-ended questions of, tell me more about your tobacco use. What are your thoughts on making changes to your tobacco use? There are resources available to help, and I'm happy to connect you with those resources. So we want to start with a very simple assessment. Again, can build it right into the intake and assessment, and then based off of that answer, we can move into additional questioning of what might be appropriate interventions for that individual. Again, we have 2 supportive resources that might be an appropriate intervention. The first is the Wisconsin Tobacco Quit Line. The Quit Line is a free counseling and support service. It is confidential, and there are a number of different modalities to interact with the Quit Line. Primary service is by phone, where you can pick up the phone and call and chat with the Quit coach. But for those who prefer to interact, maybe not over the phone, they can have web-based support, receive text-based support, and there's now group-based counseling that's somewhat of a Zoom format, and they can be on a video call with a number of other people who are making changes to their tobacco use. The Quit Line is available to anyone over the age of 13. It's available 24 hours, 7 days a week, simply by calling 1-800-QUIT-NOW. Eligible callers are also eligible to receive a 2-week starter kit of free nicotine replacement therapy that can be sent to their home. Now, the Quit Line is not necessarily a specific tailored resource to individuals who are pregnant, but the coaches do provide tailored individualized support. So if someone who is pregnant calls and would like support, they're going to tailor it to that individual and their experience. If you are interested, additionally, instead of just handing out 1-800-QUIT-NOW, if you would like to directly refer and directly connect your patients or clients to the Quit Line, there are a few different options for providing direct referrals. And please reach out to the regional outreach specialist in your region to learn more about this. We're happy to talk through those options with you and get a direct referral process set up for your organization. And our second supportive resource, we're really going to focus on the rest of the webinar today on First Breath. But First Breath is a program that's unique to Wisconsin. It is a free statewide program to help people make positive changes to their tobacco, alcohol, and substance use during pregnancy and beyond. This program is made through the Wisconsin Women's Health Foundation. It was started in 2001, and since that time has helped over 23,000 individuals make positive changes to their tobacco use. Additionally, It's an excellent evidence-based program that's undergone 2 randomized controlled trials as well as a cost-benefit analysis. So we know that it is a highly effective program focusing on providing tailored support to individuals during the perinatal period as well as to caregivers. A number of different services available through First Breath. Miranda is going to cover those in detail in the second half of our webinar today. So I really encourage you to stay on, and at the end of the webinar, you will be ready to start providing referrals to the First Breath program. It's an excellent, excellent resource. Just a quick reminder, I showed this information on one of the first slides at the beginning of the presentation to help set context for our discussion today and why we're focusing on this priority population. But I bring it back up and I've added a little bit of text to the bottom of this slide, part B of this section in DHS 75. And part B says, when a waitlist exists for services for pregnant women, the service shall either initiate interim services or notify the department within 2 days. So I would encourage you, if you are a DHS 75 provider, referring your clients or patients that are on a waitlist to receive services, referring them to the quit line or to First Breath could help meet these requirements for interim services. If we're starting that assessment right away with intake and someone screens positive, and you ask if they're interested in receiving a referral, completing that referral might help fulfill this requirement for you. So with that, I will say thank you so much for listening to part 1.